This is a textbook example of institutional betrayal.
What did they do?
The General Medical Council, the GMC, which is the official regulatory body that licenses and polices doctors in the UK, initially claimed they had no power to act as a representative body regarding the patient safety issues he raised. They essentially washed their hands of the clinical danger.
But they certainly found their power when it came to silencing him.
Precisely. A few years later, in 2012, the GMC utilized its immense authority to impose punitive sanctions directly on Dr. Srivatsa for speaking out. They targeted his fitness to practice, they subjected him to endless, grueling investigations, they even demanded psychiatric evaluations.
Wait, a psychiatric evaluation? Just because he pointed out that algorithms were causing antibiotic overprescription.
It is a notoriously common and brutal tactic used by massive institutions to discredit whistleblowers. If you can label the whistleblower as unstable, you never have to address the substance of their claims.
That is sickening. And the human cost of this retaliation on Dr. Srivatsa was absolutely staggering. Because he tried to uphold his oath and protect patients from dangerous administrative protocols, he basically lost his career.
He lost almost everything.
The immense, relentless stress of fighting the state machinery destroyed his personal life, leading to a divorce. He was financially ruined. He had to sell his house just to fund his legal defense.
Just to defend himself for telling the truth.
He went from being a respected physician to living as a paying guest in a small room in London, fighting a legal battle that dragged on for nearly a decade. He didn't finally secure a victory in the Court of Appeal until 2018.
And the darkest part of this story is that Dr. Srivatsa is not an isolated case. The psychological warfare waged by these regulatory bodies is systemic and it's lethal.
We have the historical data on this, and it's grim.
It indicates that over a decade, the trauma, isolation, financial ruin, and profound public humiliation of GMC investigations drove more than 100 doctors in the UK to commit suicide.
100 doctors.
And in the United States, facing similar pressures from medical boards and insurance conglomerates, the number of physician suicides is estimated at 400 annually.
That's horrifying.
The very regulatory systems that publicly claim to exist solely to protect patients are actively, aggressively destroying the doctors who actually try to defend medical ethics.
The moral collapse is just visible everywhere if you know where to look. Let's look at how the institutions speak to the public. The Royal College of General Practice actually ran advertisements in major newspapers telling people not to book appointments with their doctor for common ailments like a cough, the flu, or a fever. They explicitly told the public to just manage it at home, look it up online, or ask a pharmacist.
Which, from a foundational clinical perspective, is highly unethical. As Dr. Srivatsa points out, no symptom is 100% self-limiting 100% of the time.
Right, we talked about the cough earlier.
Exactly. A cough can be a simple rhinovirus, or it can be the first subtle sign of walking pneumonia, or a severe emerging infection. Every person has a fundamental ethical right to consult a physician when they are suffering.
It's a basic right.
For a medical institution to actively advise the public to stay away from medical care, knowing full well that some percentage of those people are harboring serious illnesses, simply to save the system money and reduce administrative backlog, is a dangerous abdication of their sacred duty.
So let's look at the ultimate consequence of this entire century-long shift. We have a medical system built by industrialists to prioritize the sale of patented pills. We have modern administrators aggressively replacing diagnostic doctors with flowcharts and cheaper staff. We have a public that has been systematically trained to demand a pill for every minor symptom, and a system that eagerly hands them out to get them out the door. What is the biological fallout of this?
It's massive.
It's the absolute abuse of the one true, genuine miracle that modern medicine accidentally stumbled upon: antibiotics.
This brings us to the most immediate existential threat facing global healthcare today: antimicrobial resistance, or AMR.
Explain AMR for us.
To understand the gravity of AMR, you have to understand the foundation of modern medicine. Nearly the entire edifice of complex modern medical intervention, open heart surgeries, organ transplants, cancer chemotherapy, joint replacements, even something as simple as putting a catheter in a patient, it relies entirely on one massive assumption.
Which is?
It relies on the assumption that if an infection occurs during or after the procedure, we have a pill or an IV drip of antibiotics that can quickly and easily kill that bacteria.
But because of the systemic descaling, the reliance on algorithms over diagnosis, and the profit-driven rush we just talked about, we have spent decades handing out antibiotics like candy.
Yep.
We really have.
And in doing so, We have essentially trained bacteria to defeat our weapons. How does that biological process actually work? How does a bacteria learn to beat an antibiotic?
Well, bacteria are incredibly ancient, highly adaptable organisms. They multiply rapidly.
Hmm.
When you introduce an antibiotic into an environment, say a patient's body, it kills the vast majority of the susceptible bacteria.
Okay.
But if the course of antibiotics isn't strong enough, or if it's the wrong kind, or if it's used unnecessarily, a tiny fraction of the bacteria might survive because they carry a random genetic mutation that gives them a slight defense. Sometimes the mutation changes the shape of the bacteria's cell wall so the antibiotic can't attach. Sometimes the bacteria develops what's called an efflux pump, which literally pumps the antibiotic back out of the cell as fast as it entered.
Wow, that's smart.
Once those resistant survivors are the only ones left, they multiply. Now you have a whole colony of bacteria with the bulletproof vest.
And it gets worse, right?
Right.
Oh, yeah. And worse, bacteria can engage in horizontal gene transfer. They can literally pass the genetic code for resistance to other completely different types of bacteria nearby, like sharing the blueprints for the bulletproof vest.
So they teach each other.
Through our systemic abuse of these drugs, we have accelerated this evolutionary process to a terrifying degree.
Let's put some specific numbers on this abuse. The data shows that in the UK alone, the people who are generally healthy but anxious about minor symptoms make 57 million unnecessary visits to general physicians every year.
57 million.
This massive influx costs the NHS roughly £2 billion annually. And because the system is rushed, and because the practitioners are often relying on algorithms rather than taking the time to explain the nuances of viral versus bacterial infections, millions of those visits end with an unnecessary antibiotic prescription.
We are squandering the miracle drug on the common cold.
We really are. And this is not just a UK administrative problem. This is a terrifying global biological crisis. To illustrate how pervasive this is, our sources dive into a very specific, deeply alarming piece of research.
The Palestine study.
Right. This is a master's thesis conducted by a researcher named Zina Mohammed Salim O'Day from An-Najah National University in Palestine. Her team decided to investigate a place you would normally assume is absolutely immaculate, the radiology department at a major tertiary care hospital.
Right, the radiology department.
When you picture an MRI machine or a CT scanner, you picture the absolute pinnacle of high-tech, pristine, multi-million-dollar medicine. You assume it's completely sterile.
Of course you do.
But Zina and her team went in and systematically swabbed 160 different surfaces in these rooms. They swabbed the computer keyboards used by the technicians, the patient examination tables, the ultrasound machines, and the internal components of the MRI machines.
And what they cultivated from those swabs is just the stuff of nightmares.
Let's look at the specific data points they uncovered. They measured the bacterial contamination in something called colony-forming units, or CFUs, per square centimeter.
To give you context, a CFU represents a viable bacterial or fungal cell capable of multiplying into an entire colony.
Okay, so what did they find?
They found that the computer keyboards used by the radiology staff had between 1.2 and 8 CFUs per square centimeter. The patient examination tables where sick, vulnerable people actually lay down had between 1.2 and 20 CFUs per square centimeter.
That's a lot of bacteria.
Even the highly specialized knee coils, which are placed directly around a patient's joint inside the MRI machine, had 2.4 to 3 CFUs per square centimeter. Almost every single surface they tested was contaminated with viable bacteria.
But the number of bacteria isn't even the scariest part of this study. It's the kind of bacteria they found living on those machines. They didn't just find standard, run-of-the-mill, easy-to-treat bugs. What exactly were they cultivating?
They found some of the most dangerous pathogens known to modern science. They found MRSA methicillin-resistant Staphylococcus aureus.
Oh, wow.
They found VRSA vancomycin-resistant Staphylococcus aureus. And they found VRE vancomycin-resistant Enterococcus. These are the heavy hitters. In the medical field, these are classified as multi-drug-resistant organisms, or MDROs.
Let's focus on vancomycin for a second. Why is finding vancomycin-resistant bacteria on an MRI table such a massive red flag?
Because for decades, vancomycin has been considered one of the ultimate drugs of last resort. It's the heavy artillery you bring out when standard antibiotics fail.
So if it's resistant.
If you have bacteria sitting on an MRI table that have already figured out how to survive vancomycin, you are looking at a pathogen that is incredibly difficult and sometimes impossible to kill.
So how does an MRI room become a breeding ground for superbugs?
It comes down to the logistics of modern hospital administration. Radiology departments have incredibly intense patient traffic. You have patients being wheeled down from the ICU, patients coming in from the emergency room, outpatients off the street, all moving rapidly through the same machines.
Just a revolving door.
Because the machines are expensive and administrators want maximum throughput, the turnaround time is super rushed. The disinfection protocols are often hurried or inadequate, particularly on complex, oddly shaped equipment like MRI coils that are hard to clean thoroughly.
That makes sense.
The hospital environment itself, combined with the presence of heavily antibiotically treated patients, creates the perfect evolutionary crucible for these superbugs to thrive and spread. The very high-tech rooms you go into to get an accurate diagnosis are actively exposing you to lethal, untreatable pathogens.
So the places we have built to heal us are literally serving as vectors to infect us with superbugs. And the projections regarding this AMR crisis are basically apocalyptic.
They really are.
If we continue on this trajectory, as these core antibiotics completely lose their efficacy, the entire profession of modern interventionist medicine will come to an abrupt halt by the year 2030.
Let that sink in. 2030. That is not some distant science fiction future. That is right around the corner.
If you cannot reliably prevent infection, you cannot perform a C-section. You cannot perform a hip replacement. The entire house of cards collapses.
This brings us to a profound historical realization. The intention behind the engineered creation of modern medicine in the early 20th century, guided by men like Rockefeller and Carnegie, was fundamentally designed to monetize the management of symptoms, not to definitively cure illness.
And you can see it in the drugs we have.
Can you think of a modern synthetic pharmaceutical that actually cures a chronic disease, rather than just masking the symptom while requiring a lifetime prescription?
I really can't. I really can't.
The sources make a chilling point here. The only drugs that truly cured diseases outright were antibiotics. And their discovery was largely an accident of nature, not a product of industrial design. Now that those accidental miracle drugs are failing due to our own systemic, profit-driven abuse, a profession built on a foundation of commerce, symptom management, and pharmaceutical dependency is facing total, catastrophic system failure.
Okay, that is an incredibly bleak picture.
Yeah.
We are staring down the barrel of a post-antibiotic era, driven by a system that refuses to self-correct. But this is not where the story ends.
No, thankfully it's not.
Because when systems begin to collapse, the people who have been fighting the system begin to build lifeboats. And that brings us to the pushback. Refusing to be defeated by the GMC, the NHS, or the massive medical bureaucracy, Dr. Srivatsa took everything he had learned, his knowledge of diagnostics, his deep understanding of patient psychology, and his firsthand experience of the flaws of algorithmic medicine, and he built a counter system. Because when systems begin to collapse, the people who have been fighting the system begin to build lifeboats. And that brings us to the pushback. Refusing to be defeated by the GMC, the NHS, or the massive medical bureaucracy, Dr. Srivatsa took everything he had learned, his knowledge of diagnostics, his deep understanding of patient psychology, and his firsthand experience of the flaws of algorithmic medicine, and he built a counter system.
He created the Dr. Maya AI and the PREMA Kiosk network.
The mission of Dr. Maya is fascinating because it tackles the root causes we've discussed. It is designed to aggressively educate the public, so they are no longer fooled into believing that modern medicine possesses a magic pill for every illness, particularly viral infections.
It is a direct assault on the information asymmetry we identified as the first villain earlier.
Right. The goal is to empower people to confidently understand the biology of their own symptoms, to recognize the difference between a minor ailment and a severe threat, and to safely self-diagnose and manage those minor issues at home.
The ultimate goal is to keep them out of the system unless absolutely necessary.
Because if you know your cough is viral, you don't rush into a hospital.
Exactly. You don't demand an unnecessary antibiotic from an overworked doctor, and most importantly, you don't expose yourself to the MRSA living on the waiting room chairs.
But building an AI is one thing. Actually deploying it into the real world, when the massive medical bureaucracy is designed to crush all competition, is another. How do you implement a system like this?
You use a brilliant regulatory Trojan horse. The business plan for the PREMA kiosks is a masterclass in navigating bureaucracy. The strategy explicitly acknowledges a fundamental reality. You cannot walk into a government health department or a massive hospital syndicate and tell them you want to sell a medical diagnostic machine.
Why not? If it works, shouldn't they want it?
Because the moment you use the word diagnosis, every regulatory alarm bell in the country goes off.
Oh, I see.
The medical boards will launch legal attacks over licensing and scope of practice. The doctors' unions will fight you out of professional pride and fear of replacement. The administrators will bury you in years of red tape and compliance audits. It is an unwinnable regulatory nightmare.
So what did he do?
Dr. Srivatsa's strategy pivoted the branding entirely. You do not sell it as a medical device. You sell it as a health information kiosk and administrative triage support system.
That is genius. You bypass their bureaucratic threat radar entirely while still delivering the life-saving educational knowledge directly into the hands of the patient.
Exactly. And the tactical rollout strategy for these kiosks is equally brilliant. They are not trying to launch in the massive, wealthy, highly regulated flagship hospitals in central London.
Where are they going?
They are targeting the periphery. They are deploying in self-employed sectors, impoverished slums, and small, independent private clinics, places where the medical need is visceral, urgent, and the bureaucratic red tape is incredibly thin.
They go where the pain is the greatest and the rules are the weakest. And by doing this, they're able to gather undeniable, real-world data to prove the system works. They're able to demonstrate a staggering 300% return on investment for the clinics that install them.
And a 4-day payback period on the cost of the machine.
Wow, that financial metric is the key to penetrating the system, isn't it?
It absolutely is. When you can sit down across from a hospital financial officer and show them hard data that this triage system will pay for itself in less than a week by reducing unnecessary administrative burdens, their institutional desire for profit suddenly overrides their bureaucratic fear of innovation.
It cuts right through their conditioned-to-obey response.
Right.
But importantly, the profit generated by PREMA doesn't just get funneled up to a billionaire shareholder class. The ethical financial structure of this network is a direct, intentional countermodel to the Rockefeller paradigm. It is designed around equity.
How does the split work?
It allocates 25% of the revenue for commercial monetization, ensuring the network remains technologically advanced and self-sustaining. Another 25% is dedicated specifically to subsidizing entirely free access for vulnerable populations, pensioners, asylum seekers, people struggling on universal credit.
Which is amazing.
And the remaining 50% goes directly to the Dr. Maya Foundation, which uses the funds to launch global AMR awareness campaigns and deploy kiosks in low-income countries that are desperate for medical triage.
It is utilizing the highly efficient tools of corporate expansion, but hardwiring them for empathy and global health defense.
But of all the brilliant innovations in this system, my absolute favorite detail about the PREMA kiosks is the human element. The machines are not just left alone in a corner. They're operated by individuals called kiosk guardians.
The kiosk guardians represent a masterstroke of systemic redesign. Think about the massive waste of human capital in our current system. In the UK alone, there are over 50,000 retired nurses and doctors.
50,000.
These are professionals who possess decades of hard-won, nuanced clinical experience. They have seen thousands of patients. Yet, because of age or burnout from the administrative grind, they are out of the system, often living on modest, fixed pensions. Their vast, intuitive knowledge is entirely untapped by the modern medical machine.
PREMA brings them back. They employ these retired professionals to physically run the kiosks in their own local communities. Picture a retired district nurse running a kiosk in a community center in Leeds, or a former general practitioner overseeing one in a pharmacy in Cornwall.
It accomplishes so many things simultaneously. It provides these retired professionals with dignity, a sense of renewed purpose, and supplementary income. But most importantly, it utilizes their immense clinical intuition.
Right.
The AI provides the massive database of knowledge and the rigorous triage logic, but the Guardian provides the human reassurance. They provide the empathy, the eye contact, and the seasoned, observant eye that a software algorithm alone simply cannot offer.
They are the bridge between the cold efficiency of data and the warmth of human healing. This entirely bypasses the standard Silicon Valley model of healthcare innovation, which relies entirely on proprietary black box algorithms, massive data harvesting of patient records, and the relentless replacement of human workers to maximize profit margins.
By integrating the kiosk guardians, Dr. Maya acts as a manifestation of what Dr. Srivatsa calls swadharma in action.
Harma, what does that mean?
Swadharma is a Sanskrit concept that roughly translates to one's own right duty, or living in accordance with one's true nature and highest purpose. The current system forces doctors to act against their swadharma by making them administrators of algorithms.
I see.
Dr. Maya restores that duty. It restores agency, dignity, and personal responsibility to both the patients who are actively seeking to understand and care for their own bodies, and the true medical professionals who dedicated their lives to the art of healing.
So let's step back and look at the massive, incredible journey we've taken today. We started over a century ago looking at how incredibly wealthy industrialists deliberately and systematically crushed diverse, holistic, traditional medicine to build a monopolized, petroleum and patent-based pharmaceutical empire.
We examine how that empire, focused on commercializing symptoms rather than curing disease, inevitably led to the modern era of administrators aggressively de-skilling doctors. We saw how the nuanced art of the differential diagnosis was replaced by the rigid, fear-driven compliance of the flowchart assembly line.
We looked at the terrifying biological fallout of that assembly line. The systemic overprescription of antibiotics leading directly to the rise of superbugs like MRSA and VRSA. We saw the undeniable data proving that the very radiology rooms meant to save us are harboring the pathogens that could end modern medicine by 2030.
And finally, we saw the resistance. We saw how rogue doctors, who were stripped of their careers and subjected to psychological warfare by the very regulatory institutions meant to protect patients, are fighting back. They are utilizing AI, clever business strategies, and the untapped wisdom of retired clinicians to break the monopoly on information and hand medical knowledge back to you.
And this is exactly why understanding this deep dive matters for you personally. Healthcare is not, and should never be, a passive transaction where you simply hand your body over to a mechanic. It is a mutual contribution.
By understanding the historical origins, the corporate blueprints, and the true profit-driven motivations of this system, you can actively protect yourself. You can insulate yourself from the fear-driven compliance that pushes you into unnecessary tests, dangerous overprescription, and needless exposure to hospital superbugs.
True. Comprehensive knowledge is your absolute best defense against information asymmetry. When you understand that medical protocols are administrative guidelines, not absolute biological laws, you reclaim your fundamental right to ask difficult questions.
Exactly.
You reclaim your right to demand personalized, thoughtful care, and most importantly, you begin to trust your own understanding of your own body.
Knowledge really is power here.
Which leaves us with one final, deeply provocative question to mull over as we wrap up today. If the entire sprawling architecture of modern healthcare was designed over a century ago, not to heal you, but to manage and profit from your symptoms. Wait, strike that. If it was designed to profit from your symptoms, what happens to that trillion-dollar global empire when the one true miracle they accidentally stumbled upon, antibiotics, finally stops working?
It's a scary thought.
When the superbugs win and the operating rooms are forced to close, will we be forced to desperately remember the traditional holistic knowledge we allowed them to legislate out of existence? Or will independent, empowering systems like Dr. Maya be our only bridge to survival in a terrifying post-antibiotic world?
It's something we all need to be thinking about.
The next time you walk through those sliding clinic doors and you smell the antiseptic and you hope for a sanctuary, remember the history of the factory floor you're actually stepping onto. Thank you for joining us on this incredible deep dive. Stay curious, stay informed, and we will catch you next time.